Hello all, welcome you all to the 21st episode of Let's Talk Health by Star Hospitals Financial District. I am Dr. Sindhura Durga, Consultant Medical Oncologist working at Star Hospitals. Today we have with us Dr. Yogalakshmi, who is a Consultant Clinical Hematology, to discuss and have a closer look on a most common problem but ignored one, that is anemia.
Hi everyone.
So let us first introduce Yogalakshmi madam. So ma'am, as you are a clinical hematologist, so what are the usual problems with which patients come to you?
So at the outset I want to tell what is hematology actually, because it is a lesser known branch, and also we have quite few number of hematologists all over the country. So it is a recent branch which has started, and the hematologists deal with blood and blood disorders, both benign blood disorders and also malignant blood disorders. And coming to hematology, we have both clinical hematologists and also hematopathologist. Clinical hematologists usually treat patients of blood disorders, and hematopathologists help aid the clinical hematologist in getting a proper diagnosis for the blood related problems. So as such, hematologists deal with blood problems either in the RBC cell line, either in the WBC cell line, or the platelet cell line of the blood. But most common problem in our country is anemia. And anemia is either reduction in the hemoglobin or the RBC count in the blood. To say in simple terms, usually they say decrease in blood. But actually it is a decrease in hemoglobin or the RBC count. And it is one of the common problem in our country, and the most commonly detected problem is anemia, because we do CBC for various blood disorders, not alone for blood disorders, for other when you go for a checkup for a diabetes, when you go for a checkup for a hypertension, or when you have some kidney problems, some liver problems. The basic test they include is a CBC, that is complete blood count, and the hemoglobin is reduced in that, and that gets picked up in it.
So
and,
yeah, go ahead.
And coming to the types of anemia, actually we have various types of anemia, and the most common thing is the nutritional anemia. And apart from nutritional anemia, we have hemolytic anemias, we have anemias due to chronic blood loss, and there are some anemias which are not basically due to the problem in the blood or the production in the bone marrow, but the problem can be arising because of other organ systems, like problem with the kidney, any chronic kidney disease, any chronic liver disease, or some rheumatological problem, mainly immunological problem with the like joint pains. So all these problems can lead to anemia, something called as anemia of chronic disease. And apart from this, there is a term called aplastic anemia, where the bone marrow is not producing the blood properly. So all these conditions can lead to anemia.
So as discussed, so nutritional anemias are the common causes of anemia. In addition, there is something, the hemolytic anemias or anemias due to reduced bone marrow functioning, and as mentioned, the other liver and kidney conditions also can cause anemia. So we have been familiar with nutritional anemia that usually is seen in certain age groups and all. So what are the types of anemias and what are the age groups of patients you usually deal with?
So coming to nutritional anemia, it is mostly seen in growing children, because growing children requires, as they require protein, carbohydrates, they will also require iron for the cells to function, and for the cells to increase in size and to accumulate hemoglobin and to accumulate other proteins also. So growing children are the most common age group affected. Apart from that, reproductive age group women are most commonly affected, because sometimes they have increased blood loss, and every month because of the blood loss they will be requiring more iron to form those, to compensate for those loss. So apart from this, there are some other types of anemia which can be due to iron deficiency and also vitamin B12 deficiency,
Yes.
which these both are most common in the nutritional anemia, and that can occur in like males or females and in old age or younger age. And other than that, depending upon the types of anemia like hemolytic anemia, the age group of presentation differs.
Yes.
Like children can be affected in some inherited hemolytic anemias, and also the old age people can be affected because of some blood loss through the motion, or there can be some dysfunctional uterine bleeding in some elderly people which can cause anemias. So the age group is, all the age groups can be affected, but for nutritional, most common is growing children and reproductive age group women. And saying this, I cannot say that males will not be affected. Males are also affected with anemia, and I think you see in your specialty, where
Yes.
oncology, you see more patients, male patients presenting with anemia. So what do you think the causes of anemia in a male patient, and how do you evaluate for that?
So, though iron deficiency anemia is common in children and reproductive age women because of menstrual blood flow, iron deficiency anemia can also be seen in males, especially in elderly males. So, what happens is elderly males, when they have underlying some gastrointestinal condition, some ulcers in the stomach, some ulcers in the intestine, what happens is they have some blood loss which is not clinically visible. They may not notice any blood in the stool, or the blood may not be dark as we generally see in a case of bleed, but still patients can lose blood, which is called occult blood loss. So occult blood loss from the intestines and the stomach is one common cause of iron deficiency anemia in elderly males. So any low hemoglobin in elderly male, and which is probably suggesting us that this could be due to iron deficiency anemia. So if there is any blood loss or blood source, sometimes we a procedure called adhesive glue or cryocoagulation is what is advised. And many a times, if there is any obvious source of bleeding, that has to be eradicated. If not, then the patient can be kept on iron supplementation. So, moving on to the next part of our conversation. So, what are hemolytic anemias, and can we know what are these hemolytic anemias? How do they usually come to you, and what types of different hemolytic anemias exist?
So speaking about hemolytic anemia, what the exact term hemolysis means, that your blood cell, mainly the RBCs, is broken down within your body. That is called hemolysis, and that can take place either in the spleen or liver, or it can take place within the blood vessels also. So the bone marrow will produce the RBCs properly, but it is getting destroyed due to some causes. And this hemolytic anemia can be inherited, or it can be like acquired condition. So inherited conditions mostly present during the childhood. It depends upon which kind of inherited condition. The age group of presentation also differs, like usually thalassemia, sickle cell anemia, those kind of inherited hemolytic anemias can present by the age of 6 months to 1 year, like that. And also some hemolytic anemias can present even in the newborn period. And some inherited anemias can present later in life, like in adolescents or in adults also. Coming to the not inherited form, which is acquired form, that can usually occur in adults, but rarely in children during some infections like that. And in adults and adolescents, something called autoimmune hemolytic anemia is there,
Yes.
where the body's immune system produces some antibodies against our own blood cells, blood proteins, and that causes the destruction of the RBCs. So how do we evaluate for a hemolytic anemia means, first how do we suspect for a hemolytic anemia means, the patient will be presenting with complaints of anemia like fatigue or easy tiredness, and on evaluation there will be severe anemia. Apart from anemia, there will be jaundice also, and that jaundice will not be because of the liver. So certain parameters in the investigations will show that the liver is not involved, but this jaundice is because of the blood breaking inside the body. So to evaluate a hemolytic anemia, we will send some the basic test is the complete blood count and the liver function tests. And when we suspect that, further we have some tests to confirm which type of hemolytic anemia is there. So usually in case of if we see the blood in the microscope, we can find whether it is something related to the inherited or something related to the acquired. And when we suspect inherited hemolytic anemias, then we will be sending further tests like hemoglobin electrophoresis to diagnose certain inherited disorders. And for acquired disorders, we send something called Coombs test. So with that we can find whether it is really autoimmune or not. And if at all it's not fitting in this, then we have some other specialized investigations for other inherited anemias.
So when we talk about hemolytic anemias, as we discussed, thalassemias and sickle cell anemia are one of the important types of hemolytic anemias. So what is the age group that these patients usually present to you, and which type of thalassemia or sickle cell anemia may present at an adulthood, and what is the usual treatment that you advise for these patients?
So thalassemia and sickle cell anemia usually presents when they have a disease. It is actually inherited form in the sense we have two genes for all proteins. Yes. As an autosomal gene, we have two genes for all the proteins. One we got from our father and one we got from our mother. So if both the genes are affected, then there can be thalassemia or sickle cell anemia disease. If only one gene is affected, then they will be called as carriers. So in other ways, we call thalassemia trait. So these people will not present to you with any complaints. It is usually deducted on a routine blood test, or sometimes it can be deducted when they take a blood test for a pregnancy or for some routine health checkups like that. And in case of disease, when both the genes are affected, the thalassemia patients usually present by the age of 6 months to 1 year, when it is where we call as thalassemia major. And these people will be requiring some form of continuous therapy. Whereas there is a form called thalassemia intermedia, where they don't present in the childhood. Maybe they can present after 4 years, 6 years like that, or they can present even in an adult like 30 years, 40 years also we have seen the patients presenting for the first time. So and also for hemoglobin, for sickle cell anemia, the usual age group is 6 months to 1 year. But also they can present at any time with different kinds of complaints, like not alone the complaints related to anemia like fatigue. They can present with body pains, they can present with stroke initially, they can present with something like with the jaundice, or sometimes with a kidney problem. So it varies for a sickle cell anemia. So basically it depends upon the type of anemia, and then we can say which age group they will be presenting.
So majority of the times we see hemolytic anemia patients are given bloods, especially the thalassemia and sickle cell patients. So in addition to the blood transfusion, is there any option which can help them cure with these inherited hemolytic anemias like thalassemias and sickle cell anemia?
Yes, we have some curative options also, but what the initial treatment we give is blood transfusions, mainly in thalassemia major, where we give monthly blood transfusions, and also over a period of time after transfusing blood, they accumulate lot of iron through the blood transfusion in their body, and that iron can harm the organs like liver and heart. And so we give some tablets or injections to reduce the iron in their body. And speaking about the curative option, for both sickle cell anemia and thalassemia, and in some other forms of hemolytic anemias, we have a curative option of bone marrow transplantation. But the thing is, bone marrow transplantation should be done earlier in these patients to get a good result of the bone marrow transplantation. So after transplant, the patient will be cured of that, and they can produce their own blood in an effective way, and the bloods will not get destroyed in their body, and thus it helps them.
So what is the appropriate age if one has to be planned for a bone marrow transplant in a case of thalassemia or sickle cell?
So there is not a fixed age for that, but usually we say before 6 to 7 years, if the transplant is done in a thalassemia, that will be successful. And also in case of sickle cell anemia, usually we say before age 13 years, but it is not a fixed criteria.
So it's not just blood transfusion, it is also timely meet up with the hematologist to decide on the feasibility of stem cell transplant.
Yeah.
So if there is a thalassemia and a sickle cell anemia running in a family, so would you always advise other members in the family and siblings to get tested? And is there any way, like, would you also guide your patient's family on how to further prevent these cases in their families?
Sure. Actually, prevention is better than cure in all diseases, and it holds good for thalassemia and other inherited anemias also.
Yes.
And once if a patient or a carrier is detected in the family, we usually screen the other close related family members like siblings,
Yes.
Mothers, fathers, or the progenies. And usually we get thalassemia carriers during pregnancy. So when a pregnant woman is diagnosed with a carrier for thalassemia, then usually we see whether the husband is also affected, and if at all the husband is also affected, then there is fair good chance, 50% chance that a child can be born with the thalassemia problem. As such, disease can be there. So in those conditions, even prenatal diagnosis are there, where we can screen the baby in the womb, whether that particular genes, both the genes are there in the baby or not, and there are various options according to the parents' wish, whether to terminate or to continue the pregnancy. And also, second thing, the same holds good for sickle cell anemia also. It is also a disease which comes through both the genes. When both genes are present, that will be present. And so even in sickle cell anemia, we screen in the same way.
Okay.
And apart from these hemolytic anemias, we have an important anemia called aplastic anemia, where the bone marrow doesn't produce the blood properly. So you will also be seeing such patients in your practice. So what do you suggest as a screening or as a diagnostic modality for these kind of anemias, and whether you will be doing a bone marrow study, I mean for a diagnostic purpose, whether you do a bone marrow for all kind of anemias or in some particular anemias?
So all anemias may not require a bone marrow evaluation. So bone marrow evaluation is required when we actually are still to rule out a cause for anemia. So we have already dealt with the nutritional anemia, blood loss anemia and hemolytic anemia. So whatever investigations or the blood reports give us a clue if this is not related to nutritional, it is not related, the iron studies, B12, folic acid are all normal, and we have essentially ruled out any active blood loss, and there is as such no frank hemolysis or hemolytic anemia. That is when we suspect some other cause of anemia. And in addition to this, not just hemoglobin fall, if there is any abnormality in the white blood cells, or if there is any abnormality in the platelets, or if we suspect that there is reduced production from the bone marrow, these are the situations wherein we tend to do a bone marrow to lead us to a diagnosis. So it all depends upon the way the patients present, the basic evaluation, ruling out one on the other causes, and then proceeding towards a diagnosis.
So basically, when patients come to us and we advise for a bone marrow study to be done, the first reaction of the patient is, will it pain? So really they are apprehensive about the procedure. So what do you suggest, how the bone marrow study is being conducted, and what can a patient expect when they are undergoing the procedure?
So yes, any invasive procedure can cause mild pain to the patient, but as such, bone marrow examination is a safe procedure. It is an OPD based procedure wherein the patient need not be admitted, and he just needs to be there in the hospital for around 1 hour of time. So patient can have their food, come to us, lie down comfortably onto their left or right depending upon the choice of bone marrow, and we administer a local anesthesia and we wait for 2 to 5 minutes. Once the local anesthesia is appropriate, then we do a bone marrow procedure. So this includes two types of things, that is bone marrow aspiration and a biopsy. In case of acute leukemias, we generally limit ourselves to bone marrow aspiration and a biopsy may not be required. So the complications of a bone marrow procedure can be pain at the site and bleeding can be there sometimes, and usually this is a safe procedure and 95% of the times it is usually uncomplicated. So what we consider is it's a safe procedure and can be done even in sick patients as well. And many a times it is a myth that reduced platelets, bone marrow should not be done because there is increased bleeding risk. But bone marrow will only give us a clue to the diagnosis, especially in those patients wherein we don't know the cause of low platelets. So bone marrow is otherwise a safe procedure and can be done.
Some chemotherapy called as conditioning regimen to the patient. Whereas those who are donating, they will be given some injections to mobilize their stem cells from the bone marrow to the blood. And we collect the stem cells from the donor and then we transplant to the recipient, that is the patient who is undergoing bone marrow transplant. It is simple like a blood transfusion. The stem cells are given in that procedure only. But after this conditioning chemotherapy, then further we have to monitor various things in them, like whether they are getting some infections or not, and when their bone marrow is starting to produce the blood cells, that is called as engraftment, and then whether this graft is functioning properly or not, or the patient is getting any immune reactions to the donor cells, or any donor cells are producing any immune reaction against the body of the recipient. So these are the conditions what we see in the bone marrow.
So as we discussed about aplastic anemia, and we know that aplastic anemia is sometimes immune mediated. So there are certain drugs which are also used in aplastic anemia. Can you elaborate on this particular part of treatment of aplastic anemia?
Usually for aplastic anemia can be diagnosed in any age group. It can be in children, it can be in the adolescent, it can be in the old age also. So according to the age group, the younger the patient, we prefer bone marrow transplant if at all it is an acquired aplastic anemia. In something there is some conditions like inherited aplastic anemias also, inherited bone marrow failures we say. So in those conditions allogenic transplant will be curative, and for acquired aplastic anemia in the elderly, we usually don't go for a bone marrow transplant because the success rates are very low, and also there can be some complications also because of the bone marrow transplant which they cannot tolerate. So we go for some kind of therapies with medicines like cyclosporin, or there is something called anti-thymoglobulin, just like the immunoglobulins which we give in some other diseases. So both these medicines we use, and we have some other medicines also which we called as triple therapy. So with this we will be treating the aplastic anemia in the elderly.
So now that we have discussed about the various types of anemia, and we understand that it's a very common but underrated and ignored topic, and ignored by the patients most commonly.